Hello everyone, my name is Patty Sin. I'm a pre-hospital care specialist with Southwest Ontario Regional Base Hospital Program. With me today is Dr. Matthew Davis and Dr. Sean Doran.
Thanks, Patty, for inviting me to do this webinar here today.
Great, thanks again, Patty. Hello everybody. So by the end of this presentation regarding mandatory patch points, we hope that our paramedics will recognize the importance and rationale of the mandatory patch points, as well as review some of the mandatory patch points contained within the directives and some of the little intricacies of them and sort of issues that may have come up over time as they've been utilized over the years.
So I guess the first question that we have here is how did this topic get chosen this year for CME? Because from sitting on CME planning, we often source the topics from different areas, from paramedic feedback from the previous CME, from new provincial topics to new directives to our QA and QI process. How did the mandatory patch point topic get chosen this year?
Perfect. We've noticed during our auditing that quite a bit of the medics haven't been using the mandatory patch point, specifically usually in the cardiac arrest medical directive. Numerous reasons have been given, that they just didn't have time to do it, that they were really busy during the call, that they wanted to transport, so they weren't sure why they actually needed to utilize this directive.
Yeah, I think we also noticed a bit of a trend that in many cases one of the reasons for not patching, particularly that the cardiac arrest directive, was that the thought was out there that unless there's a specific request, that it wasn't necessary.
So that's very interesting there, Sean. So I guess some of the audit feedback that the paramedics were giving, you just mentioned that there was an idea that I pretty much know what's going to happen. The order is probably going to be to transport this patient, so I'm just going to go ahead and transport that patient. Despite this being, there's a reason why it's put in the directives as being a mandatory. Can you maybe elaborate on why there's certain mandatory patch points built within directives, and maybe specifically with the medical cardiac arrest directive?
Sure. Yeah. I mean, that one I think particularly is a good example of why there are some mandatory patch points. Usually, those cases where you have these mandatory patch points are going to be situations where they're very critical points in the patient care. They may have situations with a lot of high cognitive loading on the paramedic, as there's a lot of things occurring at the same time, and it's an opportunity to have assistance from a base hospital physician, maybe to discuss the case briefly, maybe get some insight or other ideas that may not have been considered during a really sort of a very dynamic type of call. So the idea is mainly a bit of assistance in a particularly difficult case, much the same way we would have in the emergency department, where there's lots of people around, other physicians, other nurses, other staff that may be able to provide some assistance in a challenging case and provide an opportunity to maybe consider things that haven't been considered yet.
And from your clinical experience, how often in a medical cardiac arrest are you making decisions solely on your own versus using another physician in the room or other allied healthcare staff in the room with your decision making? Is this unique to physicians versus paramedics?
No, I don't think it is at all. I think particularly in an academic center, I think we have lots of support from other physicians in our group, and in most cases, and many of you out there have probably seen when you're in the emergency department with these tough cases, you'll often see 2, sometimes 3 physicians present, and then you might even have other physicians from other services being involved. I think it's just any opportunity. We're just trying to do what's best for our patients all the time, and I don't think any of us have any problem at times sort of seeking assistance or accepting input or suggestions if it's appropriate.
So in summary, these are stressful situations, lots going on, lots to think about. The mandatory patch point is built into the directive to allow the paramedic to get another set of eyes onto the case in case there's been something that's been missed, which happens in cases, and that's in these situations that can be expected. Happens in the emergency department, so there's no shame in having to call for assistance in kind of this crisis resource management kind of model.
Absolutely. I think it's a tough job out there. You're on your own out there in a truck, and could be out in the country for all we know, and it's one opportunity to get in touch and get a little bit of help and sort of approach it with more of a team approach.
So we've discussed a little bit about the mandatory patch point, but is there other situations where paramedics should patch a base hospital physician?
Well, in fact, there's within the preamble of the ALS PCS, there's 4 indications where it describes when a patch may be necessary. Of course, we've already talked about the mandatory patch point. A second one that's described in the ALS PCS preamble is when a regional base hospital introduces a mandatory base hospital patch point. And as we've, as across the province, as we've moved towards standardization, we're really not seeing a lot. I know in the Southwest, we don't have any of these mandatory patch points that are outside of the directives, and I'm not sure, but I think they'd be very rare throughout the province. The preamble also states that you can patch for situations that fall outside of the medical directive. You cannot make a medical directive for each and every situation. There may be some unique circumstances surrounding that case. Again, similar to what Sean was saying there, is sometimes another set of years, some other thought into a case can be helpful, so that may be an indication to patch. And then the fourth one that's described in the LSPCS is when there's uncertainty about the appropriateness of a medical directive, either in whole or in part. So basically, if there's any confusion around a directive, whether or not it should be implemented or a component of it should be implemented, by all means, that's another indication to call the patch physician to discuss.
So what happens if I try to utilize one of those patch points and I can't get through?
Well, I mean, in cases where you're trying to patch through and you're having trouble doing so, we expect you to try to make every reasonable attempt. And obviously, we know that sometimes the system does not function as we would like it to. In those sorts of situations, what we're looking for in that is to let us know about it one form or another. Sometimes we catch it through auditing our patch forms, but that is all forwarded and kept track of and reported to the ministry in order to ultimately move the system forward and find improvements where we can.
So I think the best way, if as a paramedic, if you do encounter a patch failure, the best way is to enter that through our communication line. We will then receive that and forward that to the ministry to investigate. We have a mandate of 48 hours once we receive that to pass it on to the ministry. And these cases, we need to collect these cases because these are examples of how the system may be breaking down and how we have examples of where the system needs to improve. So, if it's the quality of the patch where you can't hear that patch physician, or the call gets dropped in the middle of it, these are things that we need to know about so that we can pass that on to the ministry. And in those cases where if you have a mandatory patch point and you can't get through to the base hospital physician, then you would proceed with the directive as if the base hospital physician were to give you that order. But as Sean says, then definitely try to call back and reestablish that connection with the BHP.
So we've talked a little bit about how it's important and the reasons that we do these mandatory provincial patch points. Moving forward, we're going to look at the PCP and ACP patch points and highlight some of the issues that we've seen.
So here on the slide, you can see the main PCP mandatory provincial patch points. You see the medical cardiac arrest, trauma cardiac arrest, and intravenous and fluid therapy medical directives. Patty, I know you had mentioned that there were some trends that you'd been seeing or we'd been seeing in the auditing of these. What sort of things have you noticed?
One of the big trends that I've noticed is for the medical cardiac arrest mandatory patch point, it's not being performed, especially if those patients are in a PA rhythm.
So the termination of resuscitation rules is an evidence-based rule that was researched back in the early 2000s, and basically it predicts patients that are unlikely to have a good outcome, so survival in this case. And again, with the TOR rule, there may be instances where patients may warrant transport to the emergency department for some further care. You can't write a directive or a rule for each and every patient. And so I think one of our teachings has been that you're probably unlikely going to receive a termination of resuscitation for a patient with PEA who may have a rate of 60. Very different from the patient who has a PEA of 10 or 15. Sometimes age plays a role into the BHP's decision whether or not to terminate resuscitation or field, or circumstances around the case which may not be optimal for termination of resuscitation. So again, this is a mandatory patch point, and just because you're patching because the patient meets the TOR criteria doesn't necessarily mean that the patient is or is not going to get that pronouncement in the field.
Perfect. The other question I have is, so in the intravenous and fluid therapy medical directive, we're going to be discussing a little bit about the pediatric DKA fluid boluses at the fall CME. But my question is, should we be patching for an adult that we're suspecting is in DKA and is normotensive?
So I think there's a few questions that need to be asked before making that patch. Again, is the patient truly in DKA is the first question. There's a very big difference between being hyperglycemic and in DKA. So those DKA patients, they're going to be very acidotic, so they're going to have very high resp rates. So, we're looking at resp rates in the high 20s, low 30s. They're blowing off that CO2, often very volume depleted. So in these patients who you suspect DKA, they've been in DKA before potentially, they've got this high resp rate, their end tidal CO2 is in keeping with being in DKA, and their pressure, maybe it's a bit of a softer pressure, so it's still normotensive, but it's sitting, 105, 110. These may be patients who may benefit from pre-hospital IV fluids. I guess the other question too you need to ask yourself is, what's that transport time to the emergency department? If you're loading up the patient to get going and you're going to establish an IV in the back of the truck, if you're only 4 minutes away from hospital, is that really worth the time to get on the phone and talk to a BHP? Very different from those longer transport times, that may be more warranted for a patient who's truly in DKA. But again, for a patient who's in DKA, who has a softer blood pressure, and you're only 5 minutes from hospital, then I don't think that's necessary to patch at that point. So up next, we have our ACP mandatory provincial patch points. If you're a PCP watching this webinar, by all means, you can feel free to fast forward through this component of the CME, but I still think there's value for our PCPs to understand some of these ACP mandatory provincial patch points. You may be a PCP who works with an ACP, or secondarily, you may be in a service which gets cross coverage from another service that may have ACPs working in that service. So I think it's good to be familiar with some of these patch points so you understand why that ACP may be doing the care that they are providing.
Yeah, so if as Matt said, the next few slides will cover some ACP patch points. We're not going to go through them in detail each one, but there's some that we just want to touch on, some of the highlights that we've noticed, or some trends that we've noticed over the last little while. In one of them, a good example is that medical cardiac arrest directive. Again, that one came up, and we again found that there wasn't a lot of patching occurring, or a bit of a trend that the patch point had been missed. Largely, with rationale that unless there's something specific being requested, that the patch wasn't necessary, or basically being, very busy with a lot of things to do and a difficult call that it didn't have time to do that. It's important to note that it is a mandatory patch point, and as previously discussed, a lot of the reason for that is additional support, additional approaches to the situation. Maybe things that have not been considered are basically highlighted or recognized during that patch, or that mandatory patch. Another issue that wanted to touch briefly on as well is if you're doing this following your medical cardiac arrest medical directive, and the patient gets a ROSC, there's no need to patch at that point. At that point, then you sort of transition to your ROSC medical directive and then proceed following that directive.
Yeah, we've seen cases where we've received patches. The medic was under the assumption that after giving 3 rounds of epi or 3 analysis when access wasn't available, that they, no matter what, they had to patch. But as Sean says, if that patient, after your 3rd epi does get ROSC, and there's no need to patch at that point, you move to your ROSC directive and proceed from there, and there's no mandatory patch point within that. Also up on the screen is the symptomatic bradycardia medical directive. There's a patch point built in there for pacing versus giving medication to increase that patient's heart rate. So currently that is a patch point, but a little kind of sneak peek preview of what's coming down the road. We've been at the provincial table, and we've been very vocal in trying to have this patch point removed. So down the road, with the next version of the ALS PCS, when this directive gets released, you will likely see the removal of that patch point. But until then, it is still a mandatory patch point. Please keep patching for your symptomatic bradycardia patients until the new directive is released. And so on this slide, the tension pneumothorax medical directive kind of fits in the same ballpark as the symptomatic bradycardia directive. Again, understand that this is a very stressful, time-sensitive procedure to occur. And again, the medical directors at the provincial level have also agreed that at this point with this medical directive, there is not going to be a need for a patch point in future iterations or release of this directive. So you'll probably be seeing the removal of that patch point down the road. But again, until that medical directive is released, it is still a mandatory patch point before decompressing the thorax. Similarly, with the combative patient medical directive, we've been reviewing all the medical directives in the ALS PCS, and there will be some changes to this medical directive in terms of the patch point for midazolam for the combative patient. So in the future, the need for patching to give midazolam to a combative patient who can't obtain vital signs on or blood glucose will be removed. Again, with the caveat that the current version of the ALS PCS, it is still a mandatory patch point, so still practice by that, but just wanted to give you the sneak peek of what's coming down the road. So up on the screen we have the base hospital physician patch form, and this is the form that the patch physician is going to fill out when they're speaking with you on the phone. And the interesting thing about this form is it's actually a medical legal document and becomes part of the actual patient care record.
Yeah, and that's an important thing to stress. This is an official order from a physician, and as such has to be filled out by the base hospital physician, and they're responsible for the contents of that form in its completion. So it's very, very important that this form isn't altered or written on by paramedics in any way, just because this is something that the physician is medical legally responsible for.
And another note with that is part of our patch physician education is that we've asked our patch physicians not to ask paramedics to fill out any component of that form. So they shouldn't be asking you to fill in details for that when you are in the hospital. Another thing that we just want to cover here quickly is the retro patch. Retro patches, we've seen an increase in the use of retro patches, and retro patches really should be in unique circumstances only. Every effort should be made to speak to a physician to get an order for things that fall outside of the medical directives. Specifically, we've seen a lot of sodium bicarb being used in medical cardiac arrest situations where retro patches are being completed. The reason why sodium bicarb is not part of the cardiac medical arrest directive is based on the evidence that there is really no evidence for its use in medical cardiac arrest, hence why it's not part of the medical cardiac arrest directive or built in as a patch point. And so my thoughts are, if you are so busy that you don't have enough time to call for an order for sodium bicarb, then we really should be focusing on what matters, what we know works in cardiac arrest, and that's good quality CPR, early defibrillation, and trying to reverse any reversible type of causes. And then again, if you do believe that sodium bicarb would benefit your patient, then a patch must be made. And we'll be covering some of this in the in-face CME this fall.
In summary, you now understand why we need to do the mandatory provincial patch point. You've also had a chance to review all the different patch points built into our medical directives, as well as we had a chance to review some of the special circumstances that occur when we're trying to patch. I just want to thank everybody for joining us today, and have a good day.
Hopefully this has been informative and helpful for you in your practice.
Yeah, thanks everyone.